I am the Contracts and Support Manager. I now work for the University Hospital Estates Limited, a wholly owned subsidiary of the University Hospital Southampton Foundation Trust. You're probably wondering why an estates oik like me is doing here. I have a background of water. I started off as an apprentice pipe fitter welder, so I've done everything from installing domestic water systems through my apprenticeship. After that, I then crept into the world of maintenance, which I found much more interesting. Firstly, working with the MOD, and then I went on to work for Southern Health, where I was given lots of jobs of fault finding, of why temperatures weren't being achieved, and having to create with actions on. And I was also given all these PPMs, these pre-planned maintenance tasks, where I had to go and check temperatures. You know, I spend a whole day walking around an entire ward of checking these temperatures. I didn't really take much interest in it. I didn't really know why. But then I started learning. I started figuring out what was happening. I then eventually went to work at UHS, and I then started working my way, you know, up the greasy corporate pole, as it were, where I was starting to learn more about what these temperatures meant, what these parameters were for, why we were doing this. And it's the acute ending of the job that we do in estates, and that's what makes it interesting for me. That's why I love working for the NHS. I then took a little sabbatical of moving around to a few other locations, private healthcare. I even worked for a holiday park in the New Forest as the maintenance manager at Sandy Balls. I don't know if any of you are aware of it. It's very good, isn't it? Lovely place to work. And then I got the opportunity to go back to UHS, initially as the water hygiene manager. Great, everything I'd learned was all coming together, because at the holiday park I had a very steep learning curve into hot tubs, vile things. Glad to be away from them. So yeah, as a water hygiene manager, and then another step up the ladder got me to the contracts and support manager, which also meant then I can do one of the roles that I'm most passionate about, and I am the water hygiene responsible person for the trust. How does this one work? There we go. Right, there we go. So, challenges. My challenges at the trust are a very long list. But the main aim for me as the water hygiene RP is to maintain the hospital's water's highest standard to protecting the patients, visitors and staff from waterborne pathogens. I also have to make sure I have a team around me that are capable of achieving the standards. So I need to make sure I've got competent people that are doing the remedial work. So I need to make sure I've got competent contractors to do my servicing, my sampling. It's all in a part to deliver the service from the estates team. Now, our most renowned of our microbacteria is Legionellosis, Legionnaire's disease. This issue is great because it's purely systemic issue in the water supply. It can only proliferate in certain conditions when the temperature is above 20 degrees and below 50 degrees Celsius, in stagnant water or in direct sunlight, and so on. This results in water safety management being able to implement control measures to mitigate and manage the issue and initiate the remedial actions. And this process is clearly defined in L8 guidance, HSG 274 Part B, and also in the Health Technical Memorandums 0401 Part B as well. So everything's there, it's in the book. I know exactly what we're doing with Legionella. As soon as a problem arises, I can send the right people to go and deal with it. This all changes when Pseudomonas aeruginosa unwelcomely appears at one of my outlets. This microgram bacteria can arrive in various routes of transmission, as we spoke about before, including the contact contamination of services or equipment, exposure to contaminated water, soil, coming into direct contacts with other people, and even pets, especially tropical ones, apparently are very good at holding it in scales. So, in 2024, healthcare-associated infections, sorry for this is not really my territory, but cost the NHS an estimated £2.7 billion, according to the British Medical Journal Open Guest et al. These results in longer stays in hospital, more drugs being used, raising the risks, and unfortunately many unwanted outcomes for the patients, which is something nobody wants. So, what is my solution to this, or what is my suggestion? We start working together. Legionella's great. You can give that one to the estates department. They will go and cut the dead legs out. They will make sure that the temperatures are being achieved. Pseudomonas isn't. Pseudomonas is an everyone problem. So one of the 3 trust core values at UHS is working together. Like I said, it's not a maintenance issue, and we need to start collaborating to mitigate, reduce, or even remove these risks. So, by show of hands, does anyone here know what a water safety group is? Good. That's reassuring to see, because a lot of people don't. So this is a multi-disciplined group of experts formed to undertake the commissioning, development and ongoing management of the water safety plan. It's not Pete's job, it's everybody's job. So those that will be included in this will be the IPC, microbiology, the domestic cleaners, project staff, estate staff, facility staff, water contractors, and most importantly, the clinical and department leads, the people on the shop floor. In my earlier slides, I showed there was a picture there of keep it clean, keep it moving, keep it hot, keep it cold. When passed this out amongst some of the wards, the nurses would not know what I was talking about. So it's a great sign to show that if you're sharing your information, you're imparting your knowledge, and that this is how we can start to make the difference. So for my example, we have a children's cancer ward on site, devastating place enough. So we had an issue with ongoing Pseudomonas aeruginosa positive cases. They were moving around, they were never in the same place. Some were really long term, some would be for a few months. So what I did, I tried to go it alone, because I did feel that it was my job to do this. So various trials were put in place at the affected outlets. The first one was to take the outlet out of use, put in a temporary wash-hand basin next to it, and the wash-hand basin that was out of use would then flush it every day, make sure it was cleaned, which was great. And sure enough, the positive sample cleared. However, this was very disruptive. One, we had to disinfect the temporary wash-hand basin every day. We had to find an electrical supply for the temporary wash-hand basin, which meant cables, and was also very disruptive to the staff because stuff was in the way for them. So that wasn't really the answer. Point of use filters, which will be discussed in great depth later, I believe. These are great, but they are only a sticking plaster. They're not solving the problem, and they are, again, at cost. They harbour Legionella, they harbour Pseudomonas, and all we're doing is swapping the filters and resampling every month and having the same outcome. This is not ideal. One of the other ones, and quite very well effective, included an enhanced cleaning regime. So a contractor was paid, an external contractor, a specialist cleaning company, was paid to come to the outlets that were affected and clean, to give them an extra clean. We also tweaked the SOP slightly with a bit of guidance from HSE England to make sure that the area was wiped dry before it was cleaned. Also making sure that tweezers were given to the cleaners so that they could pluck out any debris that was in the waste pipes. This had a great effect. It's 66% drop, everything was going well, but cost was the issue here. And making changes to people's attitudes was also a problem. So I put together I didn't put together, with the help of IPC, we put together a water action group specific to this ward. We carried out Pseudomonas risk assessments. We assembled a team that had representation from maintenance, IPC, from the domestic contractor, from the servicing contractor. Everything went well, and then we got the actions back. It was identified that cleaning practices were not uniform. Storage of equipment, storage of patients and their wash bags, stuff all over the sinks, making it, covering the surface. There was also some issues with maintenance, taps being out of service for too long, blocked waste pipes and stuff. So we had a few things to go. But what the point is, a lot of people think they were being blamed for not doing their job, or their staff not doing their job very well. It's not blaming anyone, saying that the cleaners are bad or the maintenance guys are bad. It is saying that there needs to be a change. And when you go to the other managers and to the other heads of department and stuff, it's them that can make that change. They can enforce it, and they can, make the difference. So I also looked at some other research papers as well. There was in 2017, there was a hospital that recorded that after they had had a refurbishment, 2 years later, their Pseudomonas came back. And I also found out it was actually attributed to the fact of water jug filling. So water jugs being put in the sink, filled up and dished around. So that was quite an interesting one as well. But now we have regular meetings with the Water Action Group, and things are going well. So our outcomes. Some of the outcomes that came out from the Pseudomonas risk assessment. Shower hoses were too long and were touching the floor. Brilliant, tick. Maintenance, get up there, put some brackets in place, stop the hoses from coming on the floor. The water jugs, and this is absolutely true, the water jugs were being filled in the kitchen sink where the washing up was done. Fantastic. So after they do the washing up, they then give it a swish round and then start filling water jugs. So again, excellent. Speak to the domestics. They now fill the water jugs up in a different location to where they do the washing up. Too much clutter around the washhand basin. So patients were coming in with their wash bags, everything, all over. And so it was the cleaning staff didn't feel they had the right to go and tell them to move it. So we had a meeting, and we talked to the people, and we talked to the cleaning supervisors. Tell them to do it. If they don't want to move it, then come and send them to me, and I'll tell them to move it. I don't mind. We got the cleaning issues sorted because there was not the same person. Sometimes there was a language barrier. Sometimes people didn't know or understand or care why they were doing what they were doing. That education is now being pushed through the supervisors, and they're watching more closely what they're doing. Again, it's all adding to reducing these risks and issues. And the Water Action Group is in place. We're monitoring, we're helping each other. And I think what it was, I showed the fact that I need their help. I need your help. I can't do it as one estates manager. I can't do it with a couple of guys going around changing filters. I can't go with a couple of guys going around and checking the temperatures. We need input from everyone. So, again, as I said, the working together, and we're helping to reduce the risk for the patient, and that we're putting the patient first. We're giving them the best possible chance of not going home with anything extra. And we're always improving because we want to make the hospital a safe place in the environment. It's bad enough. I can understand that it's bad enough turning up to hospital being unwell, scared. You don't want the risk of anything else, taking anything else home with you.